Hello, ladies and gentlemen. This is CAS Lab 2 of Nanjing First Hospital of China. I'm Dr. Junjie Zhang, the moderator of the second live case. Today, there will be another very interesting case. Let me introduce my team. Today's operator is Dr. Ye and Dr. Wu. So please, Dr. Ye, introduce your team.
Thank you, Dr. Zhang, and it's my pleasure to be here today. So we will I will discuss a very interesting case, and our team is right hand is Dr. Wu Zhiming, and another is Dr. Gan, and we have a lot of nurses and technicians working here. So Dr. Wu, would you please introduce the case characteristics?
Good morning, everyone. This patient is 38 years old. Gentlemen.
So next.
Clinical presentation is chest pain for more than 1 month, aggravated for 3 days. Risk factor is smoking. Clinical diagnosis is unstable angina, old myocardial infarction, atrial fibrillation. EGFR is normal. BNP is 207.1 picogram per milliliter. Electrocardiogram showed T-valve involution in lead 1 and AVL, pathological Q valves in lead 7 to 8. Ultrasound showed hyperkinesis in anterior, posterior, and lateral wall. Ejection fraction was 40%. Next. 40 days ago, the first angiography was performed for this patient. The left main was total occlusion with thrombus. Right coronary artery was normal. There was some collateral branches to LAD. After angiography, after thrombolysis in coronary artery, thrombus aspiration and dilation from circumflex to left main. And then they finished the procedure. 1 week later, they checked the angio again. Next
PPT, please. Yes.
This is the second angiography. Right coronary artery was normal. There was also collateral branches to LAD. Next. Distal left main was 50% stenosis. Proximal circumflex was mild stenosis. We can find thrombus in distal left main and proximal circumflex. LAD was subtotal occlusion. Next. There was little blood flow in LAD. Next. For further treatment, this patient came to our hospital. This is a third angiography. Right coronary was okay. There was no collateral branch. Next. Distal left main was about 50% stenosis. Proximal circumflex was 60% stenosis, and the thrombus disappeared in left main and circumflex. LAD was diffuse and long laying. Thrombus or dissection in LAD and diagonal. Next. We calculated the syntax score. It was 34. Syntax 2 4 years mortality for PCI was 4.1%, for cabbage was 1.3%. Because this patient is very young, he refused the cabbage. According to definition 2 criteria, distal left main, maybe the complex bifurcation. LAD and diagonal was a simple bifurcation lane. Next. Do we need IVUS or OCT to guide this PCI? For this distal left main and diagonal bifurcation, do we choose 2 stand technical or 1 stand technical for this bifurcation? That's all. Okay. Thank you.
Thanks, Dr. Wu, and thanks for your introduction for this case. And this is with a very young gentleman, but with only risk factors of smoking. No other factors, just like no diabetes, no hypertension, no hyperlipidemia. So the patient will suffer from chest pain with another hospital introduction of the coronary artery. We can see the first angio showed the left main total occluded with the collateral from the RCA to the left coronary artery. But after recanalizing of the circumflex in the first PCI procedure, we cannot see any recanalizing of the LAD. But for the second angio, we can find that the LAD was reopened, but I don't know the result. The question is, what's the reason of the patients for this case? We don't know. We just want to talk about something. Today's angio, could you show today's angio? Yes, we also can see next the RCA was normal without any stenosis, but we cannot see any collateral from the RCA to the LCA again. So the collateral will disappear. This is today's angio for the left coronary artery. We also can see stenosis, moderate stenosis at the proximal to the middle part of the circumflex. This left main was moderate stenosis. But from the angio, we can see next. We can see very interesting angio result, celled just like a nailed phenomena of the proximal LAD to the middle part of LAD, including the second diagonal, just because second diagonal was large enough. For the first diagonal, we also can see this phenomena. We don't know the reason from the angio, so we can discuss now. Professor Zhang, so
yeah,
could you give me some?
Yeah, you see the very interesting case. Just as you mentioned, it's quite a younger patient with a risk only is current smoking, and think 45 days ago suffered acute heart attack with a cardiogenic shock. Actually, this case is referred from other hospital. The first, I think they didn't do the prime PCI. Only 10 days later after the symptom, the patient was stable. They do the angiogram, show left main total occluded, and also there is a collateral from the RCA to the LAD territory. So first PCI they perform successfully wire the left main to circumflex and do the balloon dilation and do the thrombus thrombectomy. Then open the circumflex. Then treated the medicine therapy. Then I think 5 days ago this patient was referred to another tertiary hospital in the Shandong province. And they do the angio again, and still show actually there is a thrombus at the left main and the circumflex. And they do the thrombus rebectomy again, and still treated with medicine therapy. At that time, LAD still actually total occluded with a collateral from RCA to supply the LAD territory. Then I think 5 days ago, this patient, after discharged from the Shandong local hospital, the patient referred to our hospital and we admitted. And today you can see actually the angiogram show LAD was reopened with TME3 flow anterior. Actually, there is no any collateral from the RCA. So according to the baseline angio of today, Actually, it's a typical left band bifurcation lesions. But from the angio, actually, you can see the circumflex lesion is moderate. But from the IVUS, from the angio, from the LAD to the left main, actually, it's a very diffuse lesion. From the distal left main to the middle LAD and to the quite long lesions. So, Dr. Ye, so I think at these times we should do the. What do you think we should do the intracorneal imaging to clarify the mechanism of the LAD to the occluded? It's a really a CTO lesion or another phenomena, a recent AMI and the thrombus resolution. So would you introduce the IVUS imaging of today's LAD and the circumflex?
Yes, we think so. The intravascular imaging is very necessary for this case, just because we want to find the mechanism of the lesion. So young patients is any other special causes of this onset of chest pain, and we just want to use intravascular imaging, just because two causes. One is coronary artery function was not very good, just because EF value was only 40%, and another is TMI flow of LAD and diagonal was not very good enough. If we use OCT, we will find the blood flush is very difficult, just because we use a very large volume and a hard energy for the blood clearing. So we think IVUS is better for the OCT. Another is if we want to get more quality of IVUS, we use 60 Hertz.
Okay.
Okay.
I fully agree. For this particular case, to I think save contrast the volumes, we should use intracorneal imaging with IVUS to detect the mechanism of this lesion.
So after we wiring the distal circumflex, distal LAD, and the distal second diagonal, we use IVUS checking. Unfortunately, we want to push the IVUS catheter distal to the distal LAD. It failed just because we feel very high resistance at the middle part of LAD. So after we check with original, IVUS detection from the just the middle to proximal part of LAD. After that, we use 2 oblong pre-dilate the middle part of LAD and recheck IVUS again from the distal part to the top of the lamina. Before this IVUS, we check the circumflex IVUS first, and then we check the LAD. I'll show you the whole IVUS detection after we perform the IVUS checking for the second diagonal. This is a second diagonal. After that, we review the previous IVUS detection.
Okay. I think it's very important that before decision making, we should check every big vessel intracorneal imaging. Yeah.
Yes. For the original angio, we find the nailed phenomena from the proximal to the distal part of LAD, including the diagonal. So we want to see what's the reason of the first and the second diagonal, even though the first diagonal was not large enough, but it was the second diagonal was large enough. This is approximately. We can stop here now. Dr. Pan, yes. Could you review the previous IVUS one by one from the circumflex to the diagonal, please?
Okay. Let me show the IVUS imaging. The first round, we check IVUS from the distal LAD to left main. And here we can see the distal vessel is normal. The vessel diameter about 2.7 millimeter. Then go and pull back, we can see the IVUS is in muscle bridge. And here the vessel is very small. The vessel diameter is just a lot more than 2.0 millimeter. Then go and pull back. In muscle bridge, we can see eccentric plaque. Then go and pull back, and the vessel diameter is more than 2.5 millimeter. Then go and pull back here. We can see in the plaque and so many holes. And this is a diagonal. We're showing LAD. This is the middle LAD. We can see in the plaque have so many holes too. And the patient is non-stemming. So we think the plaque is not the true plaque. Maybe it's organizes symbols. Then go and pull back. This is in proximal LAD. plug so many holes too, and then go and pull back. This is the LED and the circumflex bifurcation. This is a POC. This is a left main. The left main plug has so many holes too. This is also left main. The second one we check out from the circumflex to left main. Oh, sorry. This one is circumflex. The distal circumflex is normal. The vessel diameter is about 4.0 millimeter. Then go and pull back in proximal circumflex, we can see eccentric plug. Then go on here, this is a proximal circumflex, and here this point is the minimal lumen area. The area is about 3.6 millimeter square, and the plug burden is just 63%. Then go and pull back, this near the optimum circumflex. And this point is the LED and the circumflex bifurcation. This is the optimum circumflex. And here, this point, the area is about 4.3 millimeter square, and the plug burden is about 62%. And the readiness from the distal reference to optimum circumflex is about 20 millimeter. The third one we check out from the second diagonal to LAD. We can see here the diagonal vessel is normal. The diagonal vessel diameter about 2.5 millimeter. Then go and pull back, and near the diagonal, the proximal diagonal, we can see eccentric plug. Then go and pull back. This is we can see here at 9 o'clock. We can see LAD will join main vessel. And here, this is the bifurcation. And we may show the nettiness from the distal reference to optimum diagonal is about 11. Okay, this is a baseline IVUS imaging. Thank you.
So, Dr. Ye, can we show the baseline angio again?
Sure.
Actually, you can see from the baseline angiogram, after they successfully, you can see there is always filling defect, not only in the LAD, but also in the first diagonal and the second diagonal. Especially, you can see that first diagonal here is quite a lot of longer signal filling defect.
Yes.
So according to the IVUS image, just we pull back from the LAD, actually you can see there is a multiple hole, just as Dr. Pan mentioned. I think, what do you think this phenomenon? What's the mechanism? Do you think it's thrombus resolved and finally occurred with this big hole? So when we do the IVUS imaging, have we inject the contrast on the saline? Can we see the ingest of saline can go into the big hole?
Yes.
Is there any connect the hole and the lumen, Dr. Pan?
You know, unfortunately, during the IVUS detection, we did not flush the blood with contrast at that time. And Dr. Pan maybe can see there is a connection in the different channel of the thrombosis.
Yeah,
it's quite difficult even though we use yes, if we check with OCT, only just because the flow was not very good. If we use the OCT may be better, but we cannot flush the blood clearly. We can see here, maybe there is a connection from different channel. So. Yes. And after we check with LED IVUS and diagonal IVUS, unfortunately, you can see if we use a 2O balloon pre-dilator, the flow was not very good. If we pre-dilate the diagonal, the LED flow was decreased. If we pre-dilate the LED and the diagonal flow was decreased, maybe we pre-dilate the lesion in the LED or the diagonal ostia. So we cannot plaque shift from here to here, from here to there. That's why if we pre-dilate LAD, we will lose the diagonal flow. If we pre-dilate the ostia of the diagonal, we will lose the LAD flow. So next, how to do next is quite difficult. Next.
Yeah, actually, there is two big side branch of the LAD.
Yeah.
There is a big big branch of first diagonal and second diagonal. Actually, you protect the second diagonal. I think it's very important because from the angio there is a critical lesion at the ostium of diagonal 2. But how about the first diagonal? Actually,
Yes.
still there is filling defect because from the angio and IVUS we can see the ostimal circumflex is a moderate lesion. And
Yes.
also the lesion length is quite short.
Yeah.
So from our Professor Chen's the criteria of a definition criteria, actually for distal left man, it's truly a simple bifurcation. So strategy, I think maybe provisional standing is okay. But for RAD and the first and second diagonal, so what do you think? It's there is critical lesion both origin orifice of first and second diagonal. Will you protect the first diagonal?
Yes, we think if you can see if we pick the LED, we will lose the second diagonal flow. Yeah, so I think the first diagonal should be protected with a wire, just because if we're standing, it's quite easier to lose the first diagonal. We can see some data from the IVUS. Dr. Pan, would you show me the first diagonal, the site, and we can see the LED's lesion characteristics and the location of the first diagonal. Yes, here. Yes,
yeah,
we can hear.
This is the first diagonal.
It looks okay.
I think we should protect this. Yes. Even though we use a wire protect the second diagonal, maybe we can, after standing, after pre-dilation, we lost the second diagonal. After standing, we absolutely lost. So we use aggressive protection with how do you think, a balloon, angle balloon, or the jet balloon, or just a jet wire?
Personally, I think maybe jet balloon is better to protect the diagonal.
Okay. The second question is, what should we do after we check the final angel? We can see the stenosis from the very, very middle. Very different compared with the original angel. Should we standing there? Just from IVUS, we can see the myocardial bridge there.
Actually, there is no normal segment. Dr. Pan, can you reshow the IVUS result, the LD run? Is there any normal segment before the muscle bridge? Actually, a very severe muscle bridge, vessel size less than 2.0. If we put a stent, maybe there will be a risk of vessel or coronary perforation. What do you think, Dr. Pan?
I can't find the landing zone before the muscle bridge.
Wiring a little difficult for.
Very difficult.
Yes. No, this is. Give me epicorder.
So distal, the muscle bridge quite small. You see. How about the vessel size at the muscle bridge segment?
Just 2.
2, okay.
2.
I think the stent just 225.
225. We will check the IVUS again after wiring the first diagonal, and yes, give me epicranial. We will check again. We will find the landing zone of the.
Sure.
Okay.
So you go ahead, Dr. Ye.
Yes.
It's a challenger case.
Yes, this is the first diagonal.
Yeah, nice rewiring the first diagonal. Yeah.
Oh, it's quite difficult. You can hear if we waiting for a while, we will lose the first diagonal and the second diagonal.
Yeah.
So we will use the IVUS guidance standing. We cannot use angel.
Yeah.
Just because flow was not very good. Okay. Yes, user. Okay.
Will you give some GTN?
Yes. Nitro, give me. So, it's quite difficult. Look here.
Yeah, you see.
And we check the SCT before the procedure.
Yeah.
300.
300.
I think all the LD vessel is occupied by the organized thrombus.
Yes, I think so.
Yeah. After predilation, you can see a total occluded.
Yes.
The side branch in the main vessel. So we should maintain the good ACT values. Yeah.
Yes.
Otherwise, put the stent maybe no referral will be awkward at high risk.
Flush. So before the procedure, we give the patient the dual antiplatelet therapy with aspirin and ticagrelor.
Okay.
And we check their CT/SCT is good enough for PCI. So even though we cannot get a good flow result after predilation, just because diffuse means thrombosis burden.
Yeah.
So after this is
Okay.
the
This second.
diagonal.
This
Diagonal.
is
Sorry,
second
sorry.
diagonal. Yeah.
We will use LED. Which is this is LED.
Yes.
Yes, this one. Just because there is 4 wire.
4 wire.
Yes. It can be influenced by the difference wiring. And we check the OCT. We will find the distant landing zoom. And Dr. Pan, could you measure the distant landing zoom of LED to the second diagonal? Just because we don't want to standing overlapping at the side of the diagonal. It's quite difficult.
44.
Yes.
Yeah, 44.
45. I think if we will fully cover the lesion, including the muscle bridge segment, we should select the smallest stent.
Yes.
Okay.
Yes.
Yeah.
Yes.
Here I will go back. This is the first diagonal.
You're quite big, huh?
The vessel diameter is more than 2.30. Here is just 2.5.
2.5.
Yeah.
Here is negative remodeling. Yeah, very interesting.
Oh, very small here.
Do you think maybe spasm?
Yes, I think so. Just because we cannot use a natural. Just because of fluence.
Yeah, it also muscle bridge.
Yeah.
It's quite difficult.
Yeah, you see.
How to do? Mycardial bridge, we don't want to touch.
Yeah.
Yeah, the muscle bridge, we can see eccentric plaque.
Yeah.
Okay.
That's the osteoma of the first diagonal. Yeah.
We can check the flush.
And the vessel diameter is just not more than 2.5.
Yeah.
Very eccentric plaque.
Yeah.
The plaque burden very large.
Yeah.
Because during this segment, there's also the lesion location.
Yeah.
During the myocardial bridge.
Yeah. Did you predilate the lesion?
Yes, with a 2-0 balloon.
Okay. You see, same phenomenon. Yeah. Feeling the back. I think resolved organized thrombus. Yeah. Recent AMI. Yeah.
Yeah, inman vessel.
Yeah. Can you inject? Connect. Yeah, we can see. Yeah.
Okay, I will stop.
No.
Okay.
What do you think? So, if we put one stent crossover, the risk of the side branch occlusion will be high.
Yeah. There is a layer, just a thrombus layer.
Yeah.
Just a cover between the main vessel and
the side branch.
No, it's so difficult.
So something like a very neural carina, the organized thrombus. Yeah. So how to protect this very large and very big diagonal?
Yes. For my personal opinion, there is 2 resolve factors. One is use another wire in the same channel.
Okay.
During the LED with a double lumen catheter.
Okay.
Another is use aggressive protection with a balloon.
I think for this case is a recent AMI. I think we can, and actually from the echo, it's anterior and the lateral and the apex is quite hypokinesis.
Yeah.
So I think maybe actually you can see after, although the anterior flow is disappear after balloon dilation, but the patient has no symptom.
Yeah.
That's correct. Personally, I think considering it's poor IV function, I think if we can use a jet balloon protect the side branch, we can save contrast.
Sure. Okay. Give me so
2.25 stand, so
Yes.
cover from the distal landing zone.
Yes. So, Dr. Pan, would you measure the length of the distal landing zoom to the second diagonal, the distance?
44.
44. So we should put another two stand.
Yeah.
So the 2 to 5
Longest
is the
stand?
longest stand. Yes.
30. Good.
Okay.
Okay. Then followed by another 2 to 5. What's the length between the first and the second diagonal? The
13.
13. Okay.
Okay, we should 13.
Yeah.
Ah.
差不多2个30.
Yeah.
Just beyond the second
So
diagonal.
the second stand we should select the largest size.
Yeah, but we should avoid the overlapping at the muscle bridge. Yeah.
Yeah.
It's a challenging case and difficult case.
Yeah.
Nice.
Okay. So test for no, it's not touch the second diagonal. We don't use. Compared with reference angel, we can see here. It's enough.
Yeah.
Test. We cannot see that.
Yeah. Do you think? Maybe a little distal. What do you think? Oh, that's okay.
Okay.
Here I think it's okay. Yeah.
Okay.
Okay.
Nominal pressure.
Nominal. So we'll fully cover from the distal LD and the crossover the muscle branch with the 2.25
yes
by 30
no
drag loading stand. Yeah.
Yes.
Yes.
Okay. Done. This is a 30 length.
Yeah.
So we can
still need another 30. Yeah. What do you think?
Yes, I think so. Test for contrast test. Here.
Test.
We can find the flow.
Yeah, nice.
Okay,
nice.
It's better.
Yeah.
30. Okay.
So here, according to the original angiogram, actually still there in the muscle bridge.
Yes.
So what's the vessel? What's the stand size would you prefer to choose?
Yes, I think based on the IVUS detection, we use same size.
Okay.
Based on the IVUS.
Yeah, I think so.
Yeah.
2.25 by 30. So will you protect with the second diagonal with the jet balloon?
Yes, absolutely.
Okay.
It's very important to protect the side branch, even though for the first diagonal and the second diagonal, it's quite important for the patient, just because we want to use any side branch during the procedure to recovery of the patient's heart function, just because the EF value was lower.
And what's the balloon size for the jet balloon?
And Dr. Pan, do you measure the second diagonal diameter?
More than 3.
No. Second
diagonal.
Second diagonal.
Yes, this is second diagonal.
No.
The diameter of the
round 4.
Yeah.
Dr. Pan, round 4.
Round 4.
Yes, round 4.
Okay.
Yes.
2.5.
2.5. We use smaller. 2.0. 2.0 balloon. Prepare for me.
Okay. There is always a negative remodeling at the ostium side branch.
Yes.
2.0. Please give it 2.0 new balloon.
New. 15.
So would you introduce the protection, the jet balloon? I think step by step.
Yeah. And there is 3 methods for jet balloon. One is only use a balloon just to protect the side branch without any inflation during the deploying of the main vessel standing. The second is during the main vessel standing and inflation the side branch balloon simultaneously. The third is after deploying the main vessel standing, we check the flow of the side branch. If flow is okay after standing, okay, we just pull the balloon back. without any inflation during the procedure. If we find that the flow was not good after one vessel standing, we use kissing balloon. One balloon use standing balloon, another is jet balloon. One in vessel and one outside of the vessel. Then recheck the flow, and if the flow is okay, pour back the side range balloon. If we cannot find the flow, the flow is not good after kissing, so we use rewiring from the main vessel standing and perform another final kissing. That's my personal. I want to use third. Just use balloon jet, then check the flow after main vessel standing.
Okay.
So we decide. There's just 3 methods. That's okay. There's just okay.
This is your flow chart about the jet balloon, depending on the different scenarios. Okay.
Yes, some experts like to use a balloon segment to protect the side, but some experts like to use proximal part of the balloon.
Okay.
Okay.
So what's your style?
No, no change, no difference. I think so.
Okay.
Just because the second standard, we don't want to cover the first diagonal, just because we cannot use 2 jet balloon technique during the one standard deploying in the main vessel. So check, test for wire test. No, it's quite difficult.
Yeah, maybe need to see overlapping. Sure. We have overlapping already.
No, we don't. So standing overlapping and proximal is okay. We can pull it back.
Pull it back.
Yes, pull it back. Yes, we did not want to touch the first diagonal. Okay. Yeah. No, just in here. We don't use contrast. Okay, standing okay.
Yeah, overlap.
Deploy.
I think it's a good position. Yeah.
Yeah. Nominal pressure. Okay. Okay, done. No, we don't want to go up.
Go start later with the stand balloon at the overlapping segment. Yeah.
Okay, done. We will check the. Okay, test. To check the
flow of the diagonal. Yeah.
Okay. We can see the diagonal was disappear. Okay, we perform kissing. One inside the main vessel, one outside the main vessel.
Yeah.
This is a 2 balloon.
It's a very big side branch.
Okay.
So
yes, kissing. 6, 8. Okay, done. Okay, check the flow. Okay.
Not recovered.
Yes, we recover. We dilate again. We find the severe stenosis at the ostium side range.
Yeah.
Okay.
The patient hemodynamic is stable. There is no chest pain.
Yes, no chest pain. Maintain for a while. If we still find the osteo side range stenosis after main vessel standing,
you will rewire.
Yes, I will rewire kissing and maybe use drug-coated balloon.
Okay.
Yes. Okay, done. Just because the side range was large enough.
Yeah, very younger patient.
Yes.
On the longer term, I think we should keep the big vessel open.
Yes. Yeah. Okay. This is jet.
Okay. So Dr. Pan, so how about the vessel just before the second diagonal?
Okay, done.
3.0 or 3.5?
3.5.
Yeah, I think so. So what's the length? We should fully cover from the middle LED to the proximal to the left main. Yeah. Still 30. Or maybe longer.
Okay. Well, you can see the flow of the diagonal. Second diagonal was not good enough. Yeah. We also lost the first diagonal flow.
Yeah, you see. it's a challenge.
So
at this point, so Dr. So you will rescue the second diagonal and do the kissing, then perform the third standing, or you will perform third standing. So which first?
Yes, to recovery the
second diagonal.
second diagonal first. But
Okay.
before, I just want to pre-diagonal the first diagonal. We want to recover
Yeah.
is the first diagonal flow.
Okay.
We don't want to make the ischemic time for longer.
Yeah.
Give me 2 balloon.
I fully agree.
Which is the first diagonal. First diagonal here.
Yeah.
Okay. Just
Right.
because the final angel, we can see the first diagonal flow was lost.
Yeah.
It's quite interesting. We are standing. When we also lost the first and the second diagonal flow. After that, we even though, could you show me the final angel? Yes, even though the second diagonal flow was recovered, but the TIMI flow was not very good.
Yeah.
So I just perform the rewiring.
And
then perform
hissing.
hissing. If still failed, we use. Okay, first. Okay, bench 6. Yes. Okay, done. Okay, 6. Okay, done. Okay, prepare another wire. Dr. Wu, could you please check test for the flow of the first diagonal? Okay. Okay, we can see the first diagonal flow recovery after pre-dilate with a 2 balloon at 6 atmosphere, but the second diagonal flow was not good. So for me, yes.
You will use the 5th wire.
Yeah.
To rewire the second diagonal.
Yeah.
It need a very high skill. Yeah, because it's only I think 7 French guiding cassette.
Yeah.
So Dr. Ye, you are the master of the PCI. So would you introduce to the young fellow how to avoid the wire wrapping, especially for this complex PCI?
Yeah, it's a challenge procedure just because the more wiring in the same guiding cassette, if we totals for over 180 degree, we should go back. If we use only one direction to rotate the wire, if wiring more, so we will make the crossover of the wiring during the guiding cassette or in the coronary artery. So another very useful technique is to use double channel caster. If it is possible, just use micro channel caster to go into the AID and use based on this micro caster, the overlapping of the wiring phenomena was lower. If we push the wire in the guiding caster, we don't tortoise, just push. Push.
Okay. Yeah, just as Dr. Ye mentioned, another useful method of avoiding wiring wrapping is to use a dual lumen cassette. Yeah.
You can find that if we met some resistance here, it's a phenomenon that there's a lot of overlapping here.
Yeah.
Just a push. Okay. Give me AP quarter. Yes, it's not in the. Just because a lot of wiring in the LED.
Yeah, I think
there is an angulation between the LED and the left main. From the spider view, we can see the angulation, but we cannot. Okay. So. Go give me Toka. Yes. If still failed, we use a double channel caster prepared for me.
Yeah, prepare the dual lumen cassette.
Yes. The question is, so many wire has located in the. Okay.
Another resolution, actually, we can we pull out the circumflex wire? because we will not at this time we will not touch the
Yes.
distal left main. Yeah.
Yes, very good recommendation. This is a
circumflex.
yes. We will decrease the number of the wire in the.
Now there is 5 wire in
Yes.
the
This
vessel.
yes.
Yeah. Now it's better.
Yes, it's better. I think it's better.
Mm. Quite angulated of the ostimal LED. Yeah.
Yeah. Okay.
Good. Nice.
Okay. AP cranial or RL cranial?
What's wire, Dr. Jin?
Run through.
Run through. Okay.
Run through. Okay, test for wire. Oh, we were lost again.
Yeah.
You can see if still failed. Prepare just a conventional microchannel, microcaster for me. Single channel. We don't want to use a double channel. Single. Give me 1.6.
Fine cross. Yeah.
Yes, fine cross. I just want to make the tip of the wire angulation more.
Yeah.
There's okay. Give me a microcaster. Sometimes we should. There is some burst nailed.
Yeah.
Just to cover the
ostimal diagonal. Yeah.
Yes.
Sometimes, yeah, at this time, I think there will be difficulty for the rewire in the side branch. Yeah.
Yes. And give me AP cranial. AP cranial. Yes.
Yeah.
You can see the osteo. Hold the wire, please.
But we have the jet wire.
Yes.
Yeah.
That is a marker.
Yeah.
It's quite important. Yes.
Maybe we'll change the wire tip curve. Yeah.
Mm-hmm.
Make a big
Yes,
and
big
the
curve.
angulated curve.
No. Give me the wire. Okay. Give me talker and test. Okay, wait a moment.
Okay.
Yes, test. Ah.
Yeah.
Still failed. Give me a XD wire. Fit XD, please. Okay, we got it.
Okay, nice rewiring.
2 balloon.
Yeah.
And 2.5 NC balloon.
2.5.
Yes.
So from this case, you can see we should have very good projection to fully expose
LED.
the bifurcation side with microcassette. Exchange ductile, exchange, modify the wire tip angle and diameter.
2.5.
And finally, still use previous run-through wire successfully rewiring the second diagonal.
Yes, hold the wire, please.
Then followed with a 2 balloon at the second diagonal and the 2.5 balloon at the main vessel, do the casing.
Yes.
And evaluate again with the angel. Yeah.
Okay, wait a moment. This is okay.
Good. So you will pull out the previous jet diagonal.
Yes.
Wire.
Yes. Inflation. 16. 16. 1.6. Yes.
Yeah.
Hold it.
Pull out the macro cassette.
Yes.
Yes.
Okay, done. Okay. Give me 2 balloon. After predilation, there is two results. If the flow was recovery after kissing, we can use DCB.
Okay.
Or if the blood pressure was not recovery,
Your prominent side branch standing, yeah.
maybe. Okay.
So distal bifurcation angle is quite small.
Yes.
What's a strategy standing technique?
So
If you use, you have to put a second stand. Yeah.
yeah. So for my original thinking about this case, I don't want to put a stand in the 6. This is a jet wire.
Yeah.
This is jet wire. Okay.
6.
6. Hold it. Okay, down.
Okay.
Down. This is tool balloon. Push in the diagonal.
Okay, nice.
There's a low resistance. Okay, inflation. 6.
6.
Hold it.
Yeah, nice. Nice balloon expansion.
Yeah,
Nice.
yeah. So we don't think the radial expansion, the resistance was not high, but during the second diagonal.
Okay.
Just because there is might be thrombosis shifting,
Shifting,
shifting
yeah,
to
yeah.
the second diagonal.
Yeah.
If we predilate and reshift the thrombosis again, so flow is good. Okay, we can get the final result. Okay, kissing with 2 overlong inside range and 2 fibrillon in the main vessel. Okay, inversion.
Good.
No, down, down. Little slip.
Yeah.
Yesterday. Okay, kissing. Okay, hold it. Okay, done. Okay, test. Check the flow.
Nice.
Okay, Sydney. Okay.
That's good.
I think
there is no significant dissection, I think.
yes.
The radial stenosis 50% for the non-left band bifurcation side branch. I think it's acceptable result.
Sure. Okay. We should standing proximally with still jet balloon tactic. Yes, you can see.
First diagonal, yeah.
Yes, yes. Okay. And
3.5 by 30. What's the length?
yes.
Actually, this is third stand. Actually, we can fully cover. Doctor, will you cover the osteo left man?
Yes.
Okay. So from left man to the proximal eddy, what's the stand length?
Maybe 30.
30. Is it enough?
No, I don't think so. We can use the final result of the stand balloon measuring.
Yeah, previously we had to do the angel with the stand balloon.
Yeah, no. Next one. Yes, this is
not enough, I think. 33, what do you think?
Yes.
There is no overlapping.
No, still over long length, just because the marker stand was still in the marker. So I think 33 or long, still longer. A little longer stand. Okay. We have 35 or 36.
36.
36, 35的。
36, 36. What do we have 36?
Yes, this is LED.
Yes,
this is LED.
LED.
This is
diagonal
2, diagonal 2, diagonal 1.
Yeah.
Okay.
Yes.
So we should pour the second
diagonal
wire to protect the
circumflex.
Okay,
yeah, agrees.
Give me AP quarter. This is the second diagonal.
What's the step?
First.
Oh yeah, that's good. 3.5 by 36 stand. It's good.
Second diagonal is okay.
What's the stand? Yeah, a GV. Okay. Okay.
You should protect the
circumflex. Yeah.
Yes. It's a test part. Okay.
Yeah, huge vessel.
Yes. We also can see there is. Okay.
So prepare 4.5?
4.5. Yes.
Yeah,
Stand.
4.5.
Then
Left main.
to balloon.
Yeah. So for the 3.5 thermos eroding stand, the capacity of overdilation can be up to 4.5 at least.
4.5.
Yeah.
Yes, 4.5. Absolutely.
Yeah, nice.
Now give me two balloon.
So one stand cross over circumflex and the first diagonal with the 2-wire jet to protect this two big side branch.
Yes.
Still, for the circumflex, jet wire is enough, but for the first diagonal, considering it's a very severe narrowing of the osteomer and a very acute distal bifurcation angle, Dr. decided to use a jet balloon, a tool balloon, to protect this big side branch.
Yeah. Okay. No. Test. We'll see the osteo. Oh, this is
36.
36. I should pull back. Wait a moment. Sydney. Ah. What do you think a little overlapping or just with the push little distally?
Yeah, I think
osteo is okay.
Yeah.
Left main.
Osteomer is okay. We should push 1 millimeter further.
Sure.
Yeah.
Just touch the second stand is enough.
Yeah. Maybe. Yeah.
Sydney?
Minimal overlapping.
Okay.
Yeah, it's good. Oh, for osteomer, what do you think?
Still pull it back.
Yeah,
yes,
I think so.
Okay.
Considering there is a 1 millimeter shorten after stand deployment.
Yeah. Not fast. Okay, still.
Do you think maybe will you change 38 or just still use?
We have 38.
Do we have 38?
Yes, please.
3.5, yeah.
Okay. 3.5.
I think 38 is.
Yeah, I think
it's better. Yeah.
Yes.
We can fully cover with the minimal overlapping the second stand with.
Yes.
That's good. What's that? Oh, nice. Okay. Lance expandation. 38. It's good. How much time do we have?
Maybe just 2 minutes.
Okay.
2 minutes. Okay.
Enough for us to deploy the main vessel stand.
Yes, I think so. It's quite an interesting case.
If possible, maybe more than another 5 minutes is better.
We can make the final IVUS checking.
Yeah.
It's quite important for this case based on the altimeter. Yeah. Oh, what's the problem?
Angulated, I think.
Yeah. No, I don't think so. Maybe. Okay. Okay, got it.
Got it. You got it. Yeah.
Yes, I shall test. Okay.
Nice.
I should pull the stand a little back.
Yeah, fully cover the osteomer left main.
Yes, I think so. It's okay. Still need a back.
Still a little back, 1 millimeter maybe.
Yes.
Now it's good.
Okay, test for the final. Test. Okay.
I think it's good. What do you say? Yeah.
Inflation.
Good. Good position. Inflation.
Stand. Yes.
Yes.
Nominal pressure is.
Check the nominal pressure of the stand. 命名压是多少?
Okay, done. Okay, 8 atmosphere.
Okay. What's the pressure?
8.
8.
So test.
11.
Okay, test.
Yeah,
okay, it's good enough for. We can use. Okay. No, we should. No, we don't want. Give me 3.5 NC balloon.
Yeah.
If we find the after personalization flow is okay, we can.
Okay.
Oh,
Doctor, will you check
check.
the angel?
Angel?
And I think you can give a brief summary for this case at this time,
Okay.
then go on the procedure. Yeah.
Yes, the final result of the flow was very good for the
Yeah.
both branch about MEMS and
Nice result.
yes,
Nice
good
result.
Yes, and after that we will use a 3.5 NC balloon to personalization at the final stand, and pull back the. Okay. Okay, I think we should pull back the jet balloon and the jet wire just
Okay.
because the flow is good.
Okay.
Or we can make the kissing outside inside the MEMS stand just because there is stenosis at the.
Yeah, I think so. I fully agree. Considering the osteomer, the first diagnosis is still severe nausea.
Yes.
So I prefer do the kissing, gel kissing. Yeah.
Okay. We use 3.5 NC balloon to pre-dilate in the stand, and the 2.0 balloon in the side branch outside the MEMS stand. Okay, pre-dilate the side branch first. 第一对角实现扩张。
Yeah.
6, only 6 nominal pressure. Okay.
Nice balloon inflation.
Okay, done.
Yeah, nice.
Okay, kissing 6, 8. Okay, done.
Okay.
Then recheck the flow. If flow is okay, we will pull back the jet wire and the jet balloon. Okay, test. Okay,
Nice.
okay.
So at this time, actually, when pull out the jet balloon, Dr. Do you have some be cautious to avoid the guiding cassette deep injury the osteo left man?
Yes, we
standing.
have.
Yeah.
Thanks, and we have two kinds of methods to avoid destroy the osteo stand outside the aortic. So use ankle balloon technique is my favorite procedure. Use same size NC balloon to anchor in the distal area in the stand, then pull back. Give me 2.5 balloon. Another is use wire. Just put in the
outside the guiding cassette.
Yes,
at
yes.
the aortic root.
Yes, to avoid destroy.
This is a very, very important method and a tip avoiding the stand deformation, especially as the osteomer left man.
Yes. So